Yes, so good morning, thank you. Thank you to the EUROSPINE organization for inviting me to give this talk. These are my declaration of interests. I actually have a few others, but these are not related to this talk. And this is the research team I'd like to acknowledge. And what I'd like to talk to you about is idiopathic and adult spinal deformity, so not the early onset. So we talk about the trunk and the chest very often in early onset scoliosis, but here I'd like to talk about adolescents and adults. And the aim is to actually demonstrate that scoliosis is not a spine deformity. We see all these spine x-rays, but it's actually a deformity of the trunk. And I think that last talk about the abdominal muscles was already showing some of this. And Ferran just also mentioned is it an athletic body or is it not an athletic body that has a spinal deformity? So maybe we should start looking more at the trunk than just at the spine. So what do we actually measure at the moment? And also, what are we missing? And in the second half of my talk, I'll talk more about the chest and pulmonary function and cardiac function. So this is where some of our own research started. We did a survey of patients, just a very open-ended survey, and we had 58 patients. We published this in the ACTA in 2020, and there were different age groups, but 45% of patients demonstrated some form of tiredness, fatigue, shortness of breath, and we couldn't quite understand what everyone was talking about, but it's certainly something that's not captured when we measure an ODI. It's not captured when we measure an SRS score. It's not captured by EUROCAL measurements. We certainly can't capture it using x-rays, but a lot of these patients talk about fatigue, shortness of breath. So following from that, we did a study where we started structured interviews. And this was a study we did together with a group in New York and funded by the SRS. We did structured interviews of patients and started to see whether we could identify what actually patients were complaining of. And we used the World Health Organization ICF classification. And we found actually that the symptoms were mostly related to cardiovascular and respiratory functions, shortness of breath, wheezing, pain when breathing. And the second group of symptoms are actually not so much related to pulmonary function or cardiac function, but exercise tolerance or intolerance. So reduced exercise tolerance. When you compare them to their peers, people have difficulty walking stairs. They can walk stairs, it's just slower. So there's much more fatigue there. And it's really difficult to try and understand how we might be able to measure that. What's going on here is it's important to realize that we've always talked about the spine, and we know that there's some relationship to the chest. And in the past, many studies have studied pulmonary function testing. The series are generally quite small. In this study by Diederik Verkempe, he actually took a meta-study of almost 9,000 patients, and he showed that with increasing curve severity, so on the horizontal axis you can see Cobb angle, and on the vertical axis you can see pulmonary function. You actually see there's quite a strong relationship that with increasing curve severity, you get reduced pulmonary function. Now 100% is normal. We say that everything above 80 is considered normal, but you can see that none of these studies had anybody above 100. So all these studies show that most of these patients are 100 to 80% of normal or even lower, and increasing Cobb angle causes reduced pulmonary function. And with every 2 to 5 degrees of Cobb angle increase, you decrease your pulmonary function if you measure it with a PFT, pulmonary function test. And an older paper, this is a classic paper by Weinstein, he showed that untreated scoliosis leads to an increase in respiratory symptoms. These are untreated, and I think that's an important distinction as we go further in this talk. There's treated and untreated, and treated as an adolescent or treated as an adult. Einar Danielsson, this is a series from Göteborg, 25 years after adolescent treatment, showed that these patients actually increased their pulmonary function. So they improved, but they improved relatively because as we age, pulmonary function decreases, and this group managed to stay stable, so relative improvement. And the important one is that because the spread is so large, some patients have very reduced pulmonary function, others have almost normal pulmonary function. And why is this? It has something obviously with the chest shape and the spine shape, but especially the patients with bad preoperative function are the ones who show improvement. So this is a long-term patient study with 15-year follow-up. So the current patients are all adults. We're talking about adult surgery today, this morning. But you see that the patients who have a bad pulmonary function as an adolescent and are treated, they're the ones who improve. The ones who are already good, stay good. The Nordic Spinal Deformity Society meeting earlier in August this year, there were two papers which were a little bit conflicting, it seemed. This is a paper by Radboud from Denmark, and they showed that especially thoracic curves are doing a little bit worse than thoracolumbar curves. The thoracic curves are also slightly larger. But they suggested that the long-term outcome is the same as the general population. However, if you then look at Hellenius at the same NSDS meeting, they showed that 1/3 of surgically treated patients actually fulfilled the criteria for pulmonary function impairment. So probably there is some contrast there, but these are probably the patients who are already not doing so well, and if you measure the absolute level, 1/3 are compromised. And finally, this is again a similar patient, but now treated as adults. So these are idiopathic scoliosis who were untreated as an adolescent. And in this paper from Nakashima, they had 146 patients, so quite a large group of adult patients. And again, the patients with reduced pulmonary function were the ones who improved. The ones who were already good didn't get much better, but they showed that there was real improvement for the patients who had a bad pulmonary function. So these are adult patients, quite different to, for example, Danielson's paper, which were adolescent patients. And this is a paper from New York, slightly contrasting again, also probably adult idiopathic patients. And they actually showed that the surgery decreased pulmonary function. So in summary, we know that many patients complain of shortness of breath and reduced exercise tolerance. We're probably not measuring it adequately. Pulmonary function testing can't probably show it well enough. And we know that if we ask patients about it, and you should ask your patients, you'll see that actually they do complain of fatigue and shortness of breath. Untreated patients, we've seen that there's a linear relationship between curve severity and reduced pulmonary function, but the individual patient can vary hugely. Untreated patients develop more symptoms over time, especially the larger curves and especially thoracic curves. And those treated at a pediatric age seem to stay stable. And those treated at an adult age, there's some conflicting evidence. So we know there's something there. We don't quite know how to measure it, and we don't quite understand the underlying cause. And this is where I get to my point. I think we need to start talking about a spinal deformity much more as a trunk deformity. There's much more going on. What is the functioning of the lungs? What's the functioning of the heart? So it's a deformity of the trunk, as you can see here. And these are the 5 points I'll go through with you briefly. Obviously, volume of the chest. Now, this is very relevant for early onset, and we're not focusing on early onset this morning. But obviously, if you have a small chest because of your early onset scoliosis, you have less pulmonary volume. And by the age of 10, you have about 75% of your length, but you only have about 50% of your pulmonary volume. Then there's chest wall stiffness. People have always talked about restrictive pulmonary function because the chest is supposedly stiffer. It is stiffer. And when I was younger, I was always taught that it's the concave lung that's in the problem because it's compressed. It's actually almost always the convex lung that's the problem because the ribs are drooping. And like a parasol which has to open and close, if the ribs are vertical and drooping, they can't open, especially as the spine moves into the convex part of the chest. So partly it's a stiffer spine, a stiffer chest. Then there's the anatomy of the airways. As you can see on this X-ray, you can actually see that the bronchus takes almost a 90-degree angle. Any air that flows through a curved tube, just like an aircraft wing, increases or decreases pressure depending on the shape of the curve. And in this case, you get obstructive lung disease because as the air flows through the curve, the bronchus actually narrows. And it's displaced. You can see the trachea and the bronchi are not in front of the spine. They're actually completely next to the spine. And this is a CT of the same boy. And actually you can see now that this boy obviously doesn't have an adult spinal deformity, but it demonstrates the case nicely. He has a thoracic lordosis. His spine is penetrating the chest. It's rotating. And you can see that his aorta has moved to the left. And his bronchus and pulmonary artery actually has to cross all the way across the spine. And you can see that actually it's the convex lung, near the red arrow, it's the convex lung that's the one that actually is reduced in volume and compromised, and that's also where the chest stiffness is. These are papers from Scotland from a couple of years ago, and they studied this looking again at the tracheobronchial tree. Idiopathic scoliosis, but obviously relevant for adults. Probably more relevant for thoracic curves than lumbar curves. And we know that adult idiopathics a lot have thoracic curves, but adult de novo scoliosis or degenerative scoliosis is mostly a lumbar curve. But to demonstrate the fact for the thoracic curves, this is a normal spine. You can see the bronchial tree, you can see the bronchus is in front of the spine and goes left and right. In a scoliosis, you can already see that that right bronchus has to take a different route. And the red, as you can see on the bottom right, the red is where there's increased pressure on the wall of the trachea. So green is low pressure, red is high pressure. And you can already see, as I demonstrated before, that you get a significant angle in your right bronchus. Now, if you then get a lordotic spine or a hypokyphotic spine, it increases significantly because as the spine penetrates the chest, the pulmonary artery and the bronchus has to cross across the spine. And you can see the red increases significantly and you get increased pressure. And then in front of the airways, you have the pulmonary artery. So blue is the pulmonary artery, green are the airways. And you can see the right pulmonary artery, RPA, actually crosses across the right bronchus intermedius. So probably we know that the anatomy of the airways changes. And I'll come back to that in a moment, because that probably influences not just the obstructive characteristics of the pulmonary function, but it may also influence cardiac function. But first we'll go to different muscle function, going back to, for example, muscle function in the abdomen. This is a study of respiratory muscle activity. And somehow with EMGs, it looks like patients with scoliosis may have some form of muscle weakness. Can't quite understand why. But then interestingly, this is not just in the intercostal muscles. ARS patients show generalized muscle dysfunction, which may contribute to reduction in exercise tolerance. So it may actually be that there's more to it than just the chest. Then obviously, one of the biggest muscles we use for breathing is the diaphragm. And you can see this girl with this significant lumbar curve, and this is obviously relevant for adult spinal deformity and degenerative scoliosis as well, is that as the diaphragm is the pump that uses most of your breathing, it's deformed, the shape is not normal, and its physiological function is significantly hampered by this deformity. And obviously, this is, again, a different case, but it's relevant for patients with a degenerative scoliosis, or neuromuscular scoliosis, or a lumbar idiopathic. Just the fact that you're curved, your diaphragm and your abdominal muscles can't function normally. Whether they're contracted or not, they can't function normally. And finally, cardiac function. Very interestingly, this is a paper from New York. They measured ultrasound, echocardiograms, and they showed that 14% of AIS patients have a little bit of tricuspid valve regurgitation. Probably there's some shape change of the heart, and it influences the right pulmonary, right heart. And 23 showed mild pulmonary hypertension, and they compared it to controls, quite a large series, who didn't have any of this. It's mild, but it's subtle, and it's important. So it could be that this right pulmonary artery, as it's compromised, actually does have some influence on pulmonary flow, arterial flow. And very interestingly, on these patients that they operated, they did the ultrasound after surgery, and they showed actually that it normalized. So they suggest, and that's important here, that elevated pulmonary artery is probably a mechanical related to the deformation of the spine and chest. And if you can normalize it, you can normalize pulmonary artery function. And this is quite a stunning one. Corrective surgery, restored right ventricular function, and may have a medical benefit for large curves. And I think this may explain some of the exercise fatigue, for example, that these patients complain about. So in summary, many patients complain of some form of shortness of breath and exercise intolerance, and they're not quite the same. I think exercise intolerance is a very important aspect for these patients. Untreated patients, there's a linear relationship between pulmonary function and curve severity. Untreated patients develop more symptoms over time, clearly. If they're treated at a pediatric age, probably it stays stable. It may be reduced but stable, or it may improve relative to age because it stays stable, especially after a fusion. And at adult age, it's a little bit conflicting. The chest is really important in these patients, and it probably plays a significant role in all patients with a spinal deformity. And that comes back to my original point. I think we should stop talking about spinal deformity. It's much more a trunk deformity, which means that just studying spine x-rays doesn't do these patients justice. It's more relevant to compromise than often has been thought. The more recent research has shown that it's actually very relevant, and it may be explained by altered bronchial anatomy, right pulmonary artery hypertension perhaps, cardiac dysfunction, chest stiffness, and diaphragm dysfunction. And it may improve after surgical correction. Thank you.
So now we have this talk open for discussion. I think we have time for a couple of short questions. So as people are approaching to the mic.
Yeah, Ferran had a question.
So may I start with one until people walk to the mic. So for severe cases, this is very obvious, you know, that the problems are there and we will operate them. And for mild cases, maybe it's okay, but we always have a problem about the gray zone as an adult, you know, like should we wait?
Yeah.
Should we do it now? Should we do it later? Is this information, if we measured it in more precision, are gonna help us for that decision as well in the gray zone?
There's something here about complexity. And we always talk about simple linear relationships. Your femur is fractured or you've got a herniated disc, and yes or no, you should have surgery. But in spinal deformity, there's so many other things come into play. Social, emotional, and physical. I'm impressed by some of the more recent work, and maybe some patients who have exercise fatigue. If you ask about it, you may be able to explain it through some of the mechanical problems, and it's not just back pain. We've always focused on back pain. We focused on leg pain, neurogenic leg pain, spinal stenosis. We know that sagittal alignment plays a significant role in fatigue, but it could be that other aspects need more detailed questioning, and actually when you start asking patients, it may be that some tolerate their stooped posture better because they have a much better exercise tolerance, and others tolerate it less, and whether it's osteosarcopenia, or mechanical compromise, or heart function. I don't think we should get an ultrasound echocardiogram on everybody, but it's interesting to see that things are functioning there. And we know we can get diaphragm function on MRIs, for example. So I don't know, I don't have the answer. I think that gray zone is exactly that group of patients where we don't have the answer, who deserve more detailed examination, just an X-ray or an MRI. And on an MRI, we can maybe measure muscle diameter, and on a CT, we can measure Hounsfield units. And I think that's much too narrow. I think there's more to it.
Yeah, Ferran.
Excellent presentation, Marinus. And I think it's an extremely relevant topic, of course. One comment from a surgical point of view is I'd like to have some ideas or comments regarding the use of thoracoplasty when we treat these patients. Because in fact this is a relevant problem for many of them, the appearance and trunk shape, and which could be the good point and balance between improving shape of the trunk and not deteriorating pulmonary function. This is one question. And the other, which is related to very limited number of cases where there is a compression of the bronchus, as you mentioned. And we know, because it has happened, that you can do kind of decompression of this bronchus, but the bronchus is not getting better. And apparently, Malaysia of the bronchus and the trachea may play a role here. And I would also like to know, or if you have any idea of that, or if you have any suggestion regarding the interaction between deformity and bronchus Malaysia.
I don't have any data. I think in the thoracic spine, as Farrell's study from Edinburgh showed, it's probably more related to lack of kyphosis and to some degree coronal shift. And the trachea with its cartilage rings, I'm sure there can be chronic Malaysia just due to the fact that the breathing for 40 or 50 years has mechanical consequences. I just don't know what they are. Your second question related, and I think so for, if you look at the de novo adult spine deformity, and that's some of the talks you've heard, like from osteoporosis, it's more lumbar focused than there. I think the diaphragm is more important for the breathing and exercise intolerance and abdominal muscles. Whereas for the adult idiopathics, I think it may actually be the chest that's more important for breathing. So I think there's a distinction between the adolescent onset and adult degenerative onset. They have, I think, different disease entities, although their final common pathway may be lack of exercise tolerance. Your other question about costoplasty and rib resections, I honestly don't know. I think that there's evidence that suggests that doing a costoplasty improves cosmesis but reduces chest function. In the past, costoplasties were done very frequently, especially with the old Harrington rods, for example, in adolescents. I just don't know what the consequences would be in an adult population with the current techniques.
Thank you very much. Thank you.
Okay. One last question.
Thank you very much for this super interesting presentation. Actually, we have done 6 years ago a finite element study where we looked at the asymmetry of interpleural pressure. And we questioned whether this could be the cause of scoliosis. And we could show that the bone is adapting to that. And I would like to discuss that maybe a little bit more in depth with you.
Yeah,
Interestingly,
this is Wilke?
yeah.
Yeah, I couldn't. You did a study 6 years ago, and I couldn't quite hear what you said.
We looked at the asymmetry of the intrapleural pressure in scoliosis patients, but that was a pure principle analysis. We just had this hypothesis, this might be the cause for scoliosis. And interestingly, when we discussed it with our friends in the deformity groups and so on, they found this very strange, our hypothesis. How could that be? Because you perfectly showed what we were hypothesizing.
So if I understand correctly, I'm not familiar with your paper, but you did intrapleural pressures and finite element analysis.
Correct.
And you showed asymmetry between the left and right chest.
Correct.
If that has an etiologic cause for spinal deformity, I would expect it to be relevant in the growing phase.
Correct.
So
that's exactly the case.
And probably the earlier, the more relevant. Mm-hmm. And potentially, if you have an asymmetry in your intrathoracic pressures, could it influence spine growth? Pressure and forces influences growth. So for me, it seems speculative. But,
of course.
But very interesting, because there's lots of mechanical theories and posterior shift and melatonin, etc. But but we also know that patients who have a chest wall problem, either through a surgery like a thoracotomy, or they have fused ribs or absent ribs, we know that patients who are born with chest wall anomalies, many develop a scoliosis. Whereas those who have a sternotomy after chest surgery do not, but those who have a thoracotomy or fused ribs do. So one of the theories that is actually, if you go back a long way, is that potentially it's a chest wall disease with a secondary spine deformity. And I think that's what you're suggesting as well.
Yeah.
So something happens in the chest, and that causes a thoracic deformity. Wouldn't explain the lumbar deformity.
Of course not.
But I'm convinced that we know it's multifactorial. And as I said before, I think my main aim of this talk is to make you all aware that just looking at x-rays of the spine is not doing our patient justice. And Klaus, I like the idea that perhaps negative pressures or positive pressures or relative pressures might actually influence chest wall growth. You've got to start with a slight deformity to get there, and then you get asymmetry. So it could be, I don't know, very interesting.
And maybe we discuss after the session. Thanks so much.
Thank you very much. Thank you, Marinus.
Okay.
And we are very happy to see you in this presentation. And I think you can continue the discussion just after
coffee break for everybody.
Yeah,
so we will come back in 30 minutes instead of 45 minutes. So 11 a.m.